I welcome them to the dais to chair the WSO Lancet Commission on Stroke, Pragmatic Solutions and Research Priorities.
Hello, it's my pleasure and privilege to have Professor Thomas with me. Professor Thomas and Mayowa, both of them are Lancet Commission co-chair, and I request Professor Thomas to introduce Mayowa for his inaugural oration. This is the third inaugural oration being given by Professor Mayowa Owolabi. Thank you.
Good evening, ladies and gentlemen, dear colleagues. It's a great pleasure and honor to be here in Mumbai again. And we are very grateful to Abhishek Srivastava and Nirmal Surya for the kind hospitality that we are given, provided, and it's a great pleasure to be here. And this is the inaugural lecture. And here it's a great pleasure and honor to introduce a good friend for many years, for quite a few years, for quite many years now, Professor Dr. Mayowa Owolabi, who is coming from Nigeria. When I first learned Mayowa, he was and still is a gifted clinician and an enthusiastic clinical researcher. And many clinical researchers are probably thinking about little molecules or subtle pathways or things like that. Tiny, maybe very important bits and pieces. But there was Mayowa, and he was thinking about quality of life after stroke. Quality of life after stroke. What a wonderful topic. And he came at the time to Berlin. I wanted to learn to know about what are the determinants of quality of life after stroke in Nigeria and in a culturally different scenario in Germany, in Berlin. And so that was really striking to me. And he came with an interview that he, as part of his doctoral thesis research, he wanted to interview our stroke survivors, the inpatients. And I said, yes, of course. But then I had a look at the questionnaire and I was scared. I was scared. He was asking about spiritual aspects. And I thought, well, our Berlin citizens, they will be scared by really being asked such questions. And but it was a lovely experience in the end, and I wouldn't have to be worried about, not at all, and so important. And now today, this has evolved, this research, and Mayowa Owolabi, you have seen all the different roles he is playing a very big role in bringing our knowledge into practice in an academic way. And I think that's ever so important to learn from clinical trials what actually are the interventions for rehabilitation that are going to create a benefit, and how can we support implementation everywhere, high-income countries and especially low and middle-income countries. And so it's a great pleasure and honor. Mayowa, come please join and talk about, let us know about the World Stroke Organization's work, Lancet Commission.
Thank you much. Can you hear me? Oh, excellent. Thank you so very much for this great opportunity and for that generous introduction. So in the next 15 minutes or so, I'm going to summarize what we did in the WHO Lancet Commission on Stroke. Actually, it was a work that took us quite some years before we were able to accomplish it. It's not yet fully accomplished because we're in the implementation phase and monitoring phase. So we came up with pragmatic solutions and research priorities to reduce the global burden of stroke. So let me give some background. NCDs are the leading cause of death globally, but in many LMICs, attention is here to shift to NCDs. 7 out of 10 deaths are from NCDs, as we know. And amongst this group, neurological conditions, chief of which is stroke, contributes the most, about $1 trillion every year, and dementia about $1.3 trillion. And of course, stroke, leading cause of death and neurological disability across the globe, across all the different world regions, as you can see. There are other neurological conditions, but of course, stroke is number one. And then when you look at it also across the life course, stroke from the working age group, and now, even now, younger age groups are getting affected from the latest GBD database, and also those who are older. Most of the burden are in LMICs. As you can see, stroke remains number one across the years. More than 101 million people are living with stroke and its aftermath globally. And 1 in 4 people are at risk of developing stroke across the life course. And in the Lancet Commission, the first thing we did was to look at the burden as part of our situational analysis and to try to project this burden over up till 2050. And you'll see that the burden is actually increasing, particularly in LMICs, in Latin America, in Sub-Saharan Africa, in North Africa, in the Middle East, particularly in the young, and particularly in even the hemorrhagic stroke is also increasing. So we eventually came up with a stroke quadrangle, which is 4 pillars. But how did we come about the Lancet Commission on Stroke? Serendipitously, May 21st, 2016, I was in Geneva as a young physician leader, and there was this gentleman, Walter Johnson, who was in the surgery group within the WHO, and said, even though stroke is the second leading cause of death, there is actually no desk or no dedicated office in the WHO that is looking at that. And he took me on a tour of the WHO campus, and we saw a very big building that was for HIV, where there was really nothing, not even a desk for stroke. And we felt that we should do something about it. That's a picture I took in his office. And that was how the commission, was initiated. So 4 pillars, we came up with the 4 pillars of the quadrangle, meaning to reduce the burden of stroke, we need to improve surveillance, be able to count the numbers, understand the risk factors, and plan the services. Prevention, meaning primary and secondary prevention to reduce the occurrence of stroke, improve acute care, and improve rehabilitation. So, and we had a methodological framework, did a situational and gap analysis, selected best evidence-based interventions and prioritized them, consider implementation of the evidence across political, legal, ethical, anthropological, and socioeconomic frameworks, and then develop the pragmatic solutions and KPIs. The first thing we did, of course, was situational analysis, and you will see that across the globe, for surveillance, for prevention, for acute care, for rehabilitation, in terms of quantity and quality of the services available, you will see that that's actually not very impressive, particularly for rehabilitation. And we knew that our job is really set for us. We have a lot of things to do to make the change. So availability of resources in stroke rehabilitation, as an example, you will see there is a gradient in terms of availability from low income to low middle income to high income, whereby the high income really had most of the services, including inpatient rehabilitation for stroke patients, including protocol for rehabilitation, including in-hospital rehabilitation, outpatient rehabilitation. The facilities were more as expected. Then we looked beyond just having guidelines to compare the effectiveness of stroke guidelines in low and middle income countries versus high income countries. In terms of quality and quantity, again, better in high income countries than low and middle income countries. And then in terms of the implementation ability of those guidelines, in terms of translatability, implementation plans, we found that across the income strata, that was not really fantastic. So the burden of stroke is projected to increase. The cost also is projected to increase up to $1.6 trillion per annum by 2050. So a lot needs to be done in terms of implementation science, improving capability, opportunity, and motivation for implementing across the 4 pillars. And this actually the take-home points First is for improving surveillance by creating affordable surveillance ecosystems that is leveraging digital tools rather than the traditional door-to-door surveys, which are usually not very useful. Which are usually very expensive, even though they are the gold standard. And then also using mobile health, which could be very useful. Then registries, stroke registries. But the problem with stroke registries is that there is presentation bias, and that may under-report the burden of stroke. Then it's important to also have a very robust system for the surveillance of the stroke, of the burden of stroke risk factors like hypertension, dyslipidemia, obesity, diabetes mellitus, because that helps us to know how we are doing in terms of prevention. Now, to improve prevention, we need to establish systems that are all of government, all of society approach. To improve acute care, we also need ecosystems that improve early recognition and early treatment in stroke units and access to thrombolytic and thrombectomy practices, and of course, rehabilitation. So we have publications that describe this in detail for primary stroke prevention worldwide, that looked at the barriers, the facilitators across service provision, workforce, across information systems, technology, finances, as well as governance structures. And then we made key recommendations that are needed for primordial, primary, and secondary prevention, targeting the major risk factors which we are familiar with. While we are preoccupied with looking at the endpoints that we want to prevent, like stroke, like ischemic heart disease or dementia, we take a step back and look at the risk factors that we need to deal with, like hypertension, obesity, which is actually increasing even from the GBD, the data sources that we're really not winning yet with these conditions. Pre-diabetes, dyslipidemia, they are all silent killers. But then you can take a step back and then see that there are also commercial and economic determinants and social determinants of these conditions and lifestyle issues which needs to be dealt with. By dealing with all of this in terms of primordial, primary, and secondary prevention, we can drastically reduce the burden of stroke globally. And that's what we recommended. And having a brain health policy, like happened in Norway, has assisted in achieving this by reducing the burden of stroke and even ischemic heart disease by about 30% over a few decades. Then for acute care, it's important to have minimal stroke services in as many places as possible, and essential stroke services that are able to offer acute therapies. And of course, in advanced centers, have both the opportunity of mechanical thrombectomy as well as thrombolytic therapy. Emergency services, including stroke ambulances, are also important. Stroke units, early recognition, early presentation, which is what determines what happens eventually. Then disability needs to be reduced, and that's by providing multidisciplinary, interdisciplinary rehabilitation services. Neurological conditions affect 3.4 billion people, and so they are the leading causes of dialysis. And so dealing with them will really help to improve the quality of life of more than 3.4 billion people across the globe. The fastest growing cause of death among NCDs are neurological conditions. And for neurorehabilitation, the aim is not just to prolong life, but to add life to years and to add meaning to life. The concept of adding meaning to life and self-realization, self-actualization is actually a very difficult concept and challenging concept, which we are taking on board even in the Lancet Commission on Neurorehabilitation, trying to engage neurohumanities. For stroke rehabilitation, there are challenges and barriers. The biggest barrier actually is in the workforce. There are gaps in terms of workforce. Perhaps task shifting and task sharing may help with those. Service provision, stroke units and stroke facilities are very few and non-existent in some countries in Africa and in some other LMICs. Financing, because most of these, the payments are out of pocket. In low and middle income countries, these financing solutions need to using universal health coverage and other financing sources are required to deal with this. Data and information, using technology for stroke recognition like fast AI and stroke 120 and so many other programs that helps with early recognition and early presentation and immediate therapy, and of course governance. Then for the Lancet Commission on Stroke Rehabilitation, on stroke, what we did, this is the rehabilitation section. was we came up with not only the recommendations, but the sources of those recommendations, the level of evidence of each of the recommendations, the resources required for implementation, the contextual and implementation framework, and eventually what needs to be done. Now, for rehabilitation, the main recommendations summarize the key messages, include the fact that assessment tools are important to monitor outcome, multidisciplinary rehabilitation services are important, innovative low-cost interventions are important, training is important, and then research, telemedicine and digital channels needs to be explored. Research priorities included multidimensional characterization of the life course, validation of the effectiveness of educational tools, some of which are available online, investments in regenerative medicine, novel medications that help with neuromodulation and neuroplasticity, low cost and accessible interventions, neurotechnologies, BCIs, and then biomarkers, and of course, rehabiliomics, so to speak, precision medicine. Barriers and facilitators for rehabilitation, of course, include workforce, include service provision, include finance, and governance. And the key recommendations are also made for skincare, for pain control, for falls, for depression, for cognition, for consciousness, for dysphagia, for aphasia, for balance. All of these details are already published. Research priorities, I think I mentioned some of them already, including looking at the effectiveness of community delivered and home delivered rehabilitation, task shifting, task sharing, neuromodulation, telerehabilitation. These are areas that need to be explored. Looking at the multidimensional characterization of the life course, risk factors for functional dependence, prognostication, performance indicators, and country coverage. So for neurology revolution, we need to bring this on board, including One Health, which was mentioned in the last session we just had. We need to look at neuroimplants, artificial intelligence, human brain project, and all that, but also neurophilosophy, neurohumanities, and neurotechnologies, and artificial intelligence, and neuroplasticity, the neurohumanities, including neurospirituality. So we came up with targets and goals, targets, recommendations, and measures of progress for rehabilitation and for the other, by 2030, for the other three pillars of the stroke quadrangle. And now we're doing the same thing. We started the journey for doing this for the Lancet Commission on neurorehabilitation, which includes stroke. This was our first meeting in Berlin, and this is the implementation ecosystem that we are going to be setting up, including implementation partners, WFNR, many other organizations, WSO, as well as WFN, and so on and so forth, who are already on board as implementation partners, commissioners, providers, policymakers, patients. This is the ecosystem that will help with not only implementation, but dissemination and monitoring and evaluation of impact as we go on. We disseminated the commission publication across different platforms and came up with video abstracts, news channels. We also are translating. So this summarizes the key take-home points. And for rehabilitation, multidisciplinary care is required, therapies, research, enlightenment, advocacy, and training. So in a nutshell, we need to work together to reduce the overwhelming and increasing burden of stroke across the four pillars of the stroke quadrangle. Thank you so very much.
Hello. Thank you very much. Professor Plats, don't go away. Thank you, Professor Mayowa, for the inaugural oration. The inaugural oration have a silver medallion and the felicitation, which I request Abhishek Srivastava, if he is around, to kindly be over here.